Good day, students. Welcome to my second class. And before I start, I thank you for the overwhelming response from you people, which is most encouraging. Without much ado, I will go to the class straight. The chapter that we are handling will be the heart and the blood vessels. And we had earlier seen aneurysms. This, of course, is a favorite picture of ours. And this again we shall and will remember. IQ is UQ and UQ is university question. A diagram of a blood vessel is something that we should have in mind. In pathology, the diagrams need not be perfect, but they should be carrying a concept. Here, this is a vessel wall where you have an endothelium, then the media composed of smooth muscle and the adventitia, a loose connective tissue with fibroblasts. I repeat again, the intima, which is the endothelium, the media and the adventitia. There are three major diseases with a similar denominator, namely arteriosclerosis, which is the same as atherosclerosis. Apart from this, we have got hyaline arteriolosclerosis, sclerosis of the small caliber blood vessels, and Monkeyberg sclerosis, which is a cystic medial calcification. Atherosclerosis is the topic for the day. Always, I emphasize something that I have learned from my teachers. Think of the subheadings. The subheadings will take you to the answer. And a topic such as atherosclerosis is vast. It is better that we do know the terms. Definition, what are the related terms, sites, incidents, the risk factors, theories of atherosclerosis, the pathogenesis, predisposing or the risk factors, morphology, diagram of course, and complications. Let us see how well and how fast we will be traversing through the various subheadings. So the definition is atherosclerosis is a disease of the large and the medium sized blood vessels, resulting in a lesion called atheroma. The Greek word for atheroma means a paste or porridge. The modern definition, of course, includes a raised fibrofatty plaque with a core of lipids under it and a fibrous cap. A raised fibrofatty plaque with a core of lipids and a fibrous cap. The word porridge is there because Sir Rudolf Virchow, the father of pathology, when he initially diagnosed it, he thought it was something like a carbohydrate or a porridge, and hence he called it as atheroma. This is a basic diagram which we shall be remembering throughout. As I had told you earlier, the vessel, it has got a lumen with the RBCs and it is lined by an endothelium. This is a normal vessel wall that we have got, Whereas here you find a lesion. It is an elevated lesion. A plaque means a lesion that is elevated above the surface. And in this, I am finding macrophages which are having lipids within them. We call them as lipid-laden macrophages. There can be the accumulation of fat, and then there can be the fibroblasts, cholesterols, etc. So this is something. And there are some strands over here which indicate fibrin. So this is the component which we shall be dealing with in detail. The theories of atherogenesis. Sometimes they do ask it, and even otherwise it is better that we know. There is a theory of insudation or imbibition. It was thought that when your blood contains a lot of cholesterol, it percolates into the wall, and that is called as imbibition or insudation. Basically, it is something like a pinocytic vesicle that is going inside. The second one by Karl Rokitansky is the theory of encrustation. Due to the dynamic blood flow, there is a damage to the vessel wall, and then there is an accumulation of the components which falls under the theory of encrustation. In the late 1980s, there was another theory, namely the reaction to injury hypothesis by R.A.T.S and Gomset, which is more or less a repetition of the theory of encrustation. Free radicals. Free radicals are having unpaired electrons. So they are quite powerful, they can cause a damage. And monoclonal hypothesis. So these are the various theories of atherosclerosis. Theory of insudation, imbibition, encrustation, reaction to injury hypothesis, free radicals, and monoclonal hypothesis. Of these, I would like you to remember at least the reaction to injury and the monoclonal hypothesis. So this is the reaction to injury by Ross and Glomset, and this gentleman facing us is Russell Ross, a surgical pathologist. The lesions in atherosclerosis. What we saw earlier was a full-fledged atheromatous plaque, but its predecessor is a fatty streak. The picture that we are seeing is the aorta. It has got a very smooth and shiny inner wall, and I identify it by means of the ostia of the blood vessels. Ostia means openings. And here I find a pale, small, yellowish white, irregular area, hardly about 2 to 3 millimeters and maybe about 1 millimeter in width. That is called the fatty streak. The fatty streak is considered to be a precursor of the atherosclerosis. It is present in children, but then as one grows, it gradually disappears. Only in one particular site of the body, namely the coronary artery, you find that the fatty streaks and the atheromatous plaque are found in the same location. Fatty streak and atheromatous plaque are found in the same location in the coronary artery, and hence it is considered to be a precursor. The next important one that we should remember is the intimal cushion. We are talking about the morphology of an atherosclerotic lesion. One is an intimal cushion and fatty streak, another one is an intimal cushion. This again is a blood vessel. This is the media, the normal media where there are the smooth muscle cells. But then there is a proliferation of all the smooth muscle cells, and it goes into the intima, and it forms a cushion-like structure called the intimal cushion. It is usually found at the sites of bifurcation of the major arteries. Where there is an arterial fork, you will be able to find the intimal cushion. So this is the second most important lesion. And the third one is the atherosclerosis as such. The word sclerosis means scarring, and athero is an artery, arterial scarring. In this picture, we are finding an advanced and a complicated stage of an atherosclerosis in which there are irregular gray-white areas, there are some areas of hemorrhage, and there are again multiple small lesions also throughout the intima. This is a more complicated or an advanced stage of an atherosclerosis. All these are outcomes of the atheromatous plaque. The sites where you can get atherosclerosis include the aorta. Aorta, there can be obstruction to the lower extremities, and therefore you get a gangrene of the lower extremity, gangrene of the foot, etc. Coronary artery, the obstruction of which can lead to a myocardial infarction. Cerebral artery, which can be obstructed and lead to a cerebral infarct or a stroke. I repeat again, aorta, coronary artery, and cerebral artery. Gangrene of the foot, myocardial infarction, and stroke. This is a favorite mnemonic of mine. D2K means desirable to know. Desirable to know means you must. It is fairly important. We should know it. There are some major risk factors. The risk factors for atherosclerosis is usually asked as a question, difficult to answer. But then there are the major risk factors which are non-modifiable. See, certain things in you cannot be modified. Your age cannot be modified. As you grow older, the risk is more. Gender, of course, it cannot be changed. Family history, similarly, there are some conditions wherein you will be having increased hypertension, increased risk of atherosclerosis, etc. And genetic abnormalities, for two particular conditions alone we shall remember. One is increased cholesterol, familial hypercholesterolemia. Familial hypercholesterolemia, and another is homocystinuria. These are the two conditions. These are all the major risk factors which are non-modifiable. When I say non-modifiable, there are some lesions which are modifiable. Hypertension, hyperlipidemia, cigarette smoking, diabetes. The four most important parameters in the pathogenesis of atherosclerosis. In this, you are finding hypertension. Because of the shearing force, it will be causing damage to the vessel wall. Hyperlipidemia, which can cause an imbibition or a damage to the vessel wall, leading to an atheromatous plaque. Cigarette smoking, again, and diabetes, both these conditions can lead to a damage to the vessel wall, resulting in atherosclerosis. There are certain lesser important factors such as obesity, a type A personality, and the low estrogen in women. Women usually have a high estrogen in their blood, and this protects them against the atherosclerosis. But after menopause, you find the risk increases. And remember, the one thing that will be definitely associated with atherosclerosis is cholesterol. No cholesterol, no atherosclerosis. Pathogenesis, the development of it. There are two things. This is the vascular lumen, in which there is a large cell called the monocyte. And there are also the floating fat granules or the lipid granules which can be found. And the monocyte, you find that it goes into the vessel wall by means of a process called as adhesion and diapedesis. Similarly, these chylomicrons and lipoproteins have gone into the vessel wall. Once they are inside, the monocyte is changed to a cell called the macrophage. The macrophage is the adult counterpart or the tissue counterpart of a monocyte. It has got certain receptors. The low density lipoprotein receptor, to which you find the lipoproteins get attached. Once there is an attachment, there is an indrawing, maybe similar to a phagocytosis or so, and then you find that the lipid granules are found within the macrophage, leading to a bubble-filled cell called a foam cell. This is a similar diagram. I want only one additional factor should be seen in this. So these are all the fat cells, the macrophages having the granules. But here is the smooth muscle cell, and the smooth muscle cell, it migrates. It migrates into the atheroma. It migrates into the atheroma and it completes the lesion. What exactly it causes, we shall see. This is a diagram that we shall and will draw. Always a little picture is worth a million words. This is the endothelium that is raised. A plaque-like lesion, an elevated lesion, which has got a fibrous cap. A fibrous cap, very simple diagram for you to draw. And this is a core of necrosis in which there will be the cholesterol debris and maybe needle-shaped cholesterol crystals. And the inflammatory cells are the foamy macrophages. We had seen the foamy macrophages. And these are the smooth muscle cells which have traveled. I repeat again, fibrous cap, a necrotic core, foam cells, and smooth muscle cells. And this is an intact vascular endothelium. Lower down is a normal vessel wall. This is a method of grading of atherosclerosis by the American College of Cardiothoracic Surgeons, in which they have mentioned, so this is a 0 grade, or there is no atherosclerosis at all, none of the lumen is affected. Here 25% of the lumen is affected. And in the next stage, you find that less than about 50% is affected. And the plaque is growing larger. The atheromatous plaque is growing larger. And in this, you find that the obstruction is more than 75% with only 25% lumen. And this is a large lesion that we are seeing. So this is a method of grading. Same diagram that we had seen in black and white, it is a colored one, wherein I am finding a necrotic core, the smooth muscles forming the fibrous cap, and then there is a rupture of it leading to a thrombus formation, and it can lead to a lot of complications which we shall be seeing. So again, I repeat, a fibrous cap, smooth muscle over here, and these are all the foamy macrophages and the needle-shaped cholesterol crystals. Complications of atherosclerosis. Again, MK. What is MK? Must know. You must know it. So it can be a vascular occlusion. A large vessel like an aorta will not be obstructed, but smaller vessels can be obstructed totally, resulting in an ischemia. Ischemia is cessation of blood flow and lack of oxygen. Ulceration, we had seen in the previous picture. There can be a loss of the lining epithelium, and in that some complications can occur. Cholesterol is present within the core, and this can be released into the blood, causing cholesterol emboli. Cholesterol emboli. Thrombus formation, again denoted in the previous picture, one of the most important complications. Once there is a thrombus, always remember embolism. Thrombus and embolism go hand in hand. It can lead to a myocardial infarction or a cerebral infarct. Hemorrhage into the plaque. So you find that these will be having vasculature that is coming inside. That can be the blood flow inside. And once there is an erosion, there can be a hemorrhage into the atheromatous plaque. So hemorrhage into the plaque. And as it grows larger, you find that there is a softening of the vessel wall leading to an aneurysm. And finally, you'll get a calcification, a pathological calcification that can be there. So important but quite simple for you to remember: vascular occlusion, ulceration, cholesterol emboli, thromboemboli, thrombus formation, hemorrhage, medial softening and aneurysm, and pathological calcification. These are again shown in this picture over here. This is a picture showing a myocardial infarction. Probably this is an ischemic disease of the brain. A vessel being obstructed, this can lead to a gangrene of the extremity. Weakness of the vessel wall may result in an aneurysm. So this is the topic as such. As I had been telling you people, remember the subheadings. The subheadings will take you to the answer. In today's class, we had seen what is an atheroma, what are all the various theories of atherosclerosis, what can be the pathogenesis of the development of an atheromatous plaque, the morphological description of an atheromatous plaque, its preceding lesions, namely fatty streak and intimal cushion, what can be the various complications. So any part of this can be asked as a question, or sometimes vaguely atherosclerosis by itself can be asked as an essay question. Our business will be to break up the question into components, into subheadings, which will take us to the answers. Thank you once again for your patient listening. Efkaristo.